I'd like to thank the organizer for this kind invitation. I'm very glad to be here on behalf of the French LT Neuro-Wilson's disease team to share with you our data about liver transplantation in very severe neurological patient, in patient who has very severe worsening. So I have no conflict of interest to declare. So as you know, Wilson's disease is this inherited disorder leading to toxic copper overload, mainly in the liver and of course in the brain. For 30% of patients, Wilson's disease diagnosis can be made from the neurological symptoms. Of course, depending on studies, it can vary from 18 to 68%. And I think this 68% is from the Polish study. In the French registry, we had 33.5% of patients who presented neurological symptoms at diagnosis. And the main initial symptoms were 50% tremor, dysarthria, writing difficulties, dystonia, gait disorder, drooling, and dysphagia. Hopefully, chelators or zinc therapy are very effective treatment in most patients. So neurological symptoms decrease or completely regress, and some may persist. The real problem from neurologists is that a patient can have neurological deterioration. This deterioration can happen at the beginning of treatment, at the initiation of treatment. So I will try to start the videos. Oops, oh, I'm sorry for that. I checked them, but hopefully. Well, the first video in the left side, it's a young man who was diagnosed at the age of 19 with Parkinson's symptoms. He had a slight dysarthria at the beginning, so it was treated by penicillamine, and rapidly this treatment was changed for trientine due to side effect. Unfortunately, 2 months after the beginning of treatment, the neurological symptoms worsened, as you can see, with this dramatic worsening of Parkinsonian syndrome, and a slight dystonia appeared. The dysarthria was worse as well, and the patient started to have some difficulty to swallow. 5 months later, here he is. So you can see that the dystonia was major, the Parkinsonism as well. He could hardly walk alone. He couldn't swallow and needed a jejunostomy, and he couldn't speak either. The second condition of neurological worsening appeared when patients stopped the treatment. So look at this young boy who was diagnosed at the age of 13. His diagnosis was made in front of mild dystonic features in lower limb, and of course with abnormal MRI, abnormal copper balance. He was treated by trientine, and he had a very nice recovery in a year, and the MRI improved as well. Unfortunately, he went back to Morocco and stopped his treatments, and 2.5 months after interruption of treatment, the patient went back to France in emergency due to generalized dystonia with status dystonica. So of course he couldn't eat, he needed a gastrostomy, he couldn't speak. His dystonia was really painful, you can see in his figure, in his face. So of course we reintroduced the trientine, we add some zinc acetate, but unfortunately those treatments had no effect. So paradoxical worsening of neurological symptoms is not so rare. It's between 11 to 24 years of 24% of neurological patients. As Thomas said, it could happen with all 3 drugs, maybe with a predominance with penicillamine. The problem is that this worsening is irreversible in more than 40% of patients, resulting in severe disability or even death. Mechanism of deterioration are known. Of course, many hypotheses are present. The first hypothesis is that treatment is too slow to act in very acute forms. Another hypothesis is that intracerebral chelation may be ineffective or there are some irreversible tissue damage already present when we start the treatment. Or the last hypothesis is that the direct effect of the treatment acts with rapid mobilization and redistribution of copper, resulting in a high level of copper in blood and brain, leading to oxidative stress and accentuation of brain tissue damage. And as you have heard before, the recommendation so far is to use this start slow and go slow regimen, especially for chelators. So, how to deal with this traumatic situation? As no other medical treatment exists, what could be the place of liver transplantation? As you know, liver transplantation in hepatic force or Wilson's disease is a recommended therapeutic option in Wilson's disease with fulminant hepatic failure or severe hepatic insufficiency. In those validated indications, results are very good, with 87% survival rate after 15 years. And it was published in a paper recently. Concerning the neurological forms, liver transplantation remains controversial in Wilson's disease with worsening of neurological features despite treatment. So far, 15 case reports on LT for strict neurological indication has been published, and it corresponded to 32 patients with heterogeneous evaluation and follow-up and various outcomes. In France, thanks to rare disease funding plans since 2005, we have the chance to have a national reference network for the care of Wilsonian patients, and of course a national Wilson's disease registry. Here is the map of France with different cities involved in the Wilson's disease patients. So we decided to make a collaborative study to report the French experience on liver transplantation in patients with pure neurological aggravation despite accurate medical treatment. And we really wanted to focus on, first, the survival rate, secondly, the long-term disability, and of course, the presence or not of prognostic factors. So we made this retrospective study between 1994 and 2016. So we looked at patients who had a liver transplantation for neurologic indication and who fulfilled three conditions. First, of course, the diagnosis of Wilson's disease should be confirmed. Secondly, and it's very important, the patient should have constant neurological worsening despite a minimum of 2 months of appropriate copper chelators. So we defined worsening as a minimum of 20% increase of the UWDRS score and a 2-point increase in the modified ranking score. The third condition was that patients should have a severe neurological impairment with a ranking score above 4 at the time of liver transplantation. For those who are not very familiar with the ranking score, just to remind you that 4 correspond to patients who are unable to walk without assistance, and 5 is an extremely severe disability, patient at bedridden, incontinent, and need a constant nursing care. Patient could have a primary worsening in newly diagnosed and treated patient, or could have a secondary worsening to the interruption of chelators or zinc salt. And there was a very important criteria of non-inclusion, which was hepatic indication of liver transplantation. So Aurélia insists it was really patient with pure neurological worsening and with pure neurologic indication of liver transplantation. We decided to look at 2 primary outcomes. The first was the overall survival rate, and the second, the disability at the last follow-up after LT, as assessed by the ranking score and the UWDRS. We arbitrarily considered that the major improvement was a decrease of the neurological score above 66%, a moderate improvement, a decrease of the score between 33% and 65%, and a mild improvement or a stable condition, a decrease below 33%. Secondary outcomes were the evolution of the ophthalmological scores and the brain MRI scores at the last follow-up. So what about the results? We could study 18 patients, and all those patients had liver transplantation during this 22 years period of time, and this transplantation was made in 5 liver transplant centers in France, and 60% of the patients had a liver transplantation in the last 6 years, as you can see in the graph in the right side of the slide. Those 18 patients concern 14% of the patients of the registry with neurological phenotype. The median age was around 18 years old, and the median time between neurological worsening and liver transplantation was almost 7 months. Concerning the characteristic of the patient before LT, so it's important to note that all have a very mild hepatic disease with child A for all patients and a median male score around 8. But when we look at the native liver, all the patients had a cirrhosis at an examination. Concerning the neurological symptoms, all were extremely severe, and I insist in this, with heavy disability. When you look at the ranking score, it was 5 in 90% of the patients. The UWDRS mean was above 100 with extremely severe neurological impairment. And the main symptoms were dystonia and Parkinsonism. 80% of patients needed jejunostomy or gastrostomy, and more than half of the patients required a tracheostomy. Concerning the brain MRI, it was abnormal in all patients with constant lenticular nucleus involvement. Just a word about the general condition. Of course, there were very fragile patients. 40% of the patients had a severe sepsis within 3 months before LT, and 5 out of 18 patients required an intensive care unit admission for acute respiratory distress syndrome in the months previous prior to LT. So what about the survival rate? Here is the curve. So you can see that at 1 year, the survival rate was 88.8%, and at 3 and 5 years, it decreased to 72.2%. 4 patients diseased, and with a median interval of almost 14 months, and all deceased due to sepsis of pulmonary origin. When we looked at severe sepsis and ICU admission in the months before LT, the two conditions were significantly associated with death, while tracheostomy and male gender tended to be associated with death. So the other patient, so the 14 patients alive, were followed for a mean 71 months, so almost 6 years. And what about the evolution of the ranking score? The median ranking score improved from the pre-LT state to the post-LT state, and it was significantly. So just to remind you, in the pre-LT state, 16 patients scored 5. So 5 is a very severe disability with patient bedridden. And at the last follow-up, 64% of patients scored above 3, just to tell you that 3 correspond to a moderate disability requiring some help, but patients are able to walk without assistance. What about the UWDRS after the mean follow-up? It improved as well, statistically, oh, it's hard to pronounce. 60% had a major improvement, 30% a moderate improvement, and 10% a mild improvement or a stable status. And what about the secondary outcomes? Ophthalmological score improved as well, and the brain MRI score improved. And the difference depending on the location with a very important amelioration in the nucleus caudate and in the pons, and a less high amelioration in the thalamus and mesencephalon. Of course, the serum copper and ceruloplasmin normalized rapidly after the LT, but we were very interested by the urinary copper excretion because it was slightly elevated in 7 patients out of the 14, and at the last follow-up. And to finish about the result, the late complication, 1 patient needed a retransplantation 7 and 11 months after the first LT due to arterial complications. 1 patient developed a Burkitt's lymphoma 3 years after liver transplantation, but he was considered into complete remission 7 years after LT. And 1 patient developed a complex partial seizures due to the extension of a cortical lesion 8 months after liver transplantation. But 3 years after the liver transplantation, the epilepsy was well controlled with a B therapy, and the UWDRS improved, as well as the basal ganglia abnormalities. So far, it's currently the largest cohort with a prolonged follow-up in the specific indication of pure neurological presentation. The main result is that the patient survival at 1 year is similar to those published for liver transplantation in Wilson's disease because of liver failure. And at 5 years, the survival rate stays reasonable since before LT, patients were all bedridden and required constant nursing care. And those patients had a constant deterioration despite chelation. And of course, this LT was proposed as a rescue treatment. The second important result is that 2/3 of the patients had a major improvement of their neurological disability. After 6 years of follow-up, 64% gained physical independence for daily living activities with a ranking above 3. 60% had major improvement of the neurological score, and all the patients had no more jejunostomy or gastrostomy or tracheostomy. And to finish with the result, the presence of a sepsis before LT and an ICU admission within the months prior to liver transplantation could be defined as a predictive factors of bad outcome. So I'd like to conclude with this word. We think, after this experience, that liver transplantation is a therapeutic option in very selected neurologic Wilson's disease patients resistant to decoupling therapies and without severe liver disease. LT may not be the solution for every patient, and we know that, but has a place as a rescue therapy while waiting for future therapies, and why not for the tetrathiomolybdate therapy. The management of transplanted patients with severe neurologic Wilson's disease is complex, and we really think that it should be handled by experienced multidisciplinary teams to improve long-term survival and neurological handicap. Of course, many questions remain, and this retrospective study doesn't answer to all the questions, and we think that we really have to make a prospective study to try to answer to those questions. When should we transplant these patients? We really think that we should not wait too long before transplanting them, but it's not be too early either. What are the good prognostic factors? We know that we distinguish very bad prognostic factors with sepsis and ICU admissions, but what are the good prognostic factors? We don't know that. And what are the mechanisms underlying the effect of LT on brain dysfunction? We talked about animal models in Wilson's disease with neurological involvements, and the animals models are very poor, and we don't know exactly what's going on in the brain. And the last question is, should chelation treatment be resumed after LT? In a few patients, we started again the trientine because of the high copper excretion in the urine, and because the patient was did not do well. So we resumed the chelation in about 4 patients. And to finish, I just wanted to show you the evolution of this young boy. I think you remember this video, this dramatic video with this dystonic status. So he had a liver transplantation 2 months after his arrival in France, and despite the reintroduction of chelators and zinc. 6 months after the liver transplantation, he could stand alone and take a few steps. You can look at his MRI. You can see that the brain lesion improved dramatically but he had a very important atrophy. 2 years after liver transplantation, patient could walk alone, was autonomous in activities of daily living. So of course his walk is not normal, but he have a lot of chorea, dystonic ataxia, so all we can see in Wilson's disease patient, but he could walk alone and was autonomous. And 12 years after the liver transplantations, he's totally independent. He got married, has children. He went back to work part-time, and his brain MRIs improved as well, but the atrophy is maintained. So I just want to thank all the team in Lariboisière Hospital who work hard in taking care of patients with Wilson's disease patients. And I very thank you for your kind attention. Here is Lariboisière Hospital. A few weeks ago, under the snow, and it was very cold and freezing. Thank you.